Good evening, everybody, and welcome to tonight's education session, which is focused on enhancing physical healthcare in mental health. This workshop tonight has been sponsored by the Adelaide PHN and also SA Health Office of the Chief Psychiatrist. My name's Helen Ho from SAPNIA. Now, before we begin tonight, I would like to start with an acknowledgement of the traditional owners of this country. We would like to acknowledge the traditional owners of the land that we meet on today. We pay respect to their elders, past, present and emerging, and to acknowledge the important role Aboriginal and Torres Strait Islander people continue to play in our communities. Now, just a few housekeeping points before we start. We would really like to keep tonight's education session interactive. We've got the audience in the room as well as those who have joined us online tonight. Our presenters and our panel members are happy to take questions throughout the workshop. So those in the room, please wave your hand. We have a roaming mic and we'll come around. For those participants who have joined us online tonight, please use the Q&A function in Zoom and we'll have your questions and comments included in the session. Now, there is an evaluation form for those in the room tonight. That form is on your tables. And for those who've joined us online, the online link will automatically pop up as soon as you exit tonight's session. Now, in terms of CPD and certificates of attendance, they will all be allocated and sent following tonight's session. So those in the room, if you missed it on your way in, please make sure you have signed in on the sign-in sheet, and those online will use your registration details to confirm your attendance. So just also for those in the room, we ask that you please do keep your mobile phones on silent, and if you do need a break, a bathroom is located through the rear door down the end of the corridor on the left-hand side. And now I would like to introduce tonight's facilitators and panel members. So we have Associate Professor Scott Clark, who's the Head of Psychiatry at Adelaide Uni and also a Consultant Psychiatrist at Western Community Mental Health Service. We've also got Dr. Jackie Yeo, who has joined us online. Jackie is a General Practitioner and also the GP Integration Officer and a Consultant at Carlin. We've also got Michelle Quirk, who's joined us here online. Michelle is a lived experience community rehabilitation worker with Trevor Parry in Noarlunga. And we've also got joining us online, Dr. Chuck Ahero, who's a cardiologist at SA Health. And in the room, we've also got Kerry Nichols, who's a senior pharmacist and also the Carlin Mental Health Team Leader. And finally, Lisa Wilton, who's the Advanced Nurse Consultant for Mental Health GP Shared Care with the Office of the Chief Psychiatrist. Now I am going to hand over to Jackie to start tonight's session.
Thank you, Helen, and apologies for not being in the room, everybody, but I didn't think you'd like the Sydney germs that I brought back from the other conference I presented at last week. Helen, can you guys hear me all right?
Yes, we can. Now, Jackie, I've got control of the presentation, so I will progress the slides for you. So if I haven't progressed the slides, just let me know. If you would like me to go back, just let me know as well.
Thank you, Helen. Always better to have you have control of things than me, is all I can say. If I could go to the next slide, and I wanted to throw this open to the floor. What things come to mind, because you will come along to this session, so you must have some interest in it. What things come to mind when you think about improving the physical health of people with mental health conditions? What things do we need to consider? Oh, darn, just ask the double question, exactly what they taught me not to do in my psychiatry training. What do people in the room think? You put your hands up, put things in the chat. What do people reckon? And I can't see people to dob on them, so you'll have to go looking for them yourself, Helen, right? Anybody want to put their hand up and have a guess?
Yes, you've got one, Jackie.
Oh,
I guess you'd be thinking about things like alcohol and nicotine intake, and as well as physical exercise. I guess diet.
Mm-hmm. Yep, all sound like really good things to be thinking about. Anything else?
Do they want to change? Do they want to improve their physical health?
Yes, that's a very valid point. Yeah, just because we think it's a good idea, that might not necessarily be the case for the person themselves. Yeah. Anything else that we might want to think about?
Jackie, I've got a comment here from an online participant, chronic pain, as well as consideration of health issues such as diabetes, epilepsy, etc.
Fantastic. Well, I hope somebody was going to come up with chronic pain, because chronic pain and mental health go together. They are such bedfellows. Absolutely right. Anything else that people want to add in before we move on? And I'll tell you what I think. Well, in that case, let's move on to the next slide, Helen, and I'll give you my little list, but recognizing that this is not exhaustive. So the next slide has, and we've talked about some of this already. I've called it inactivity rather than exercise, but it's the same thing. Yeah, diabetes, smoking, alcohol, other drugs, of course, marijuana and amphetamines, particularly, but all the other fun things that come to mind. Lipids, teeth, because anybody who works with mental health, people with mental health issues will tell you that that's a really common issue for all kinds of reasons. Blood pressure, reduced chance that you're going to get screening for cancer, delayed presentation of physical illness, malnutrition, excuse the people next door, that's our COVID gang, and they get a bit overexcited sometimes, excess weight, high lipids, and particularly loneliness and isolation, because your health outcomes if you're lonely and isolated are not good. So moving on to the next slide, because I think we covered most of that. Okay, so what's the main message of this seminar? Basically, this is something that we have to take really seriously, because the outcomes are much worse for people with mental health conditions, have much worse outcomes when it comes to physical health. And when you look at this kind of stuff, it starts to you start to realize how confronting it is. So basically, we talk about suicide as being a risk for people with mental health conditions. But in fact, it's the chronic disease that's going to get you. And it's the heart disease, the stroke, the cancer, the type 2 diabetes, chronic kidney disease. I mean, that is such a common combination, respiratory conditions. And, you know, when you look at the fact that 28 people a day are dying prematurely if you've got a mental health condition, as opposed to if you don't, that's a huge figure. 10 more times premature deaths and suicide. It's the thing that we don't tend to think about. It's the thing that we need to start thinking about. A gap of 15 years if you've got mental illness, as opposed to if you don't have a mental health condition. And then, of course, we've also got the fact that physical health conditions, it feeds back the other way. I mean, if you've got diabetes, you've got 50% higher risk of having depression. You know, physical health conditions cause mental health conditions in just the same way. So it's a mixture of all of this, and the fact that you're less likely to be employed, you're more likely to be poor, live in a lower socioeconomic area, you're less likely to have access to good services. All of those things contribute to being 5 times more likely to die prematurely. So this is serious stuff. This is stuff that we really have to think very carefully about, which is why you're here. Next slide. Okay, so we've got a question. We've got a poll now. I love polls. And I think what you're supposed to do, Helen, tell me if I've got this wrong, but you're supposed to stick your phone up, scan the QR code, and then put in the answer.
That's right. And those of us who joined online, you're able to scan that QR and answer as well.
Yeah, and then we'll be able to see all of the answers. And I think you can all probably read this, but A is 20%, B is 33%, C is 58%, and D is 70%. So have a go, see which we come up with, what gets the highest votes. And Helen will tell me when we start going through some numbers as to what people think that the most likely answer to that question is. I'm actually very interested to see whether they get it right or not. Have we got any numbers yet? Popular votes? Any joy? Well, you're not far off, guys. Oh, no, I've got to shut up a bit longer because we're going to see it change again, aren't we? How do I know, Helen, how do I know when it's at the saturation point? Is that about... Well,
It looks like those in the room have responded now.
Excellent.
Yeah.
Anybody else online who needs... there's some people, something going in the Q&A. So Well, good points in there as well. Yeah, exactly. I think, are we fairly stable now? Is that about where we've
That-
landed?
I think that's it in terms of responses.
Okay. Well, you're on the right track, guys. It is high, but it's actually higher than the majority of people thought it was. Oh, guys, got a later. It's changing. I love it. Oh, nope, they're changing their votes now. Oh my God, I love technology. I might have took a bit longer, shouldn't I? All right. Has everybody, yeah, no, they changed their votes, I reckon. Okay, let's move on to the next slide. I think we've had enough fun with the poll. All right, so basically there's your answer sitting there right in front of you, and about the fourth line down. So basically, yeah, lots of modifiable risk factors, things that as GPs and mental health clinicians we can address. No, the patient may not always want us to address them, but you know what? If we don't ask the question, we don't start talking about these things, then they won't have the chance to address them, and that's so important. It's harder for people to get into screening, treatment, surgical interventions. Oh my goodness, yes, there are all kinds of barriers that get in the way of people getting elective surgery done if they have mental health conditions. And yeah, 70% more likely to smoke, or nearly 70% more likely to smoke if you're a woman, 40% more likely to smoke if you're a man. And, you know, I did my psychiatry training 30 years ago, but C3, there was that kind of wall of smokers out the back of it, where, you know, you just couldn't sit there in the bus stop because everyone was smoking outside and people used to sort of wander out for breaks and go and smoke. So I don't think it's an awful lot different nowadays. You're more likely to be inactive, more so if you're a man than if you're a woman. Yep, absolutely good reasons why people, 1 in 3 are carrying a lot more weight than ideal, as opposed to 1 in 4 in the general population, and particularly if you've got a psychotic illness. And of course, medication is one of the huge risk factors there. And I know Scott's going to talk about that a bit more later on. But moving right along, so there's a lot of differences. And if we look, these are lovely little infographics. This comes from the Equally Well consensus statement, and we'll put up some resources later. This is absolutely worth having a look at. And yes, you can see there, it's self-explanatory really, but you're 6 times more likely to die of heart disease, 5 times more likely to smoke, that's an average obviously, more likely to die, 4 times more likely from respiratory disease, and as we said before, average of around about 15 years earlier mortality, 14 to 23 years earlier according to that infographic, but it's a heck of a difference compared to people who don't have mental health conditions. So moving on to the next slide. Okay, so why? And this is going to be a question to you lot in the room, because I think we do have to think about why. What are the factors that make people with mental health or mental health conditions more likely to have physical issues than the rest of the population? What's coming into play here? Hands up, anybody? Helen's on the road again, I hope.
I have something to say, Jackie. So I was thinking networks. So me personally, it's really hard to go to the gym unless my friend convinces me to go. So I think having those networks and having the encouragement can be really hard for people if they don't have those secure networks.
I think that's a great point. Yeah, absolutely right. There's nothing like having somebody go with you, is there? It just keeps you honest. Yeah, yeah. What do other people think? We talked about antipsychotics already.
Hi, Jackie. I'm thinking a lower income.
Yep, that's right. If you're less likely to be employed and you're likely to have had your study interrupted or your life interrupted in the late teens, then yeah, you're less likely to have an income, and that certainly gets in the way of a whole lot of things, that's for sure. What else?
Jackie, we've got a few comments from online. The symptomatology of mental health illness is often a significant barrier. Health issues of the medications that they take, lack of motivation as a symptom of their mental health, medication side effects of weight gain, hunger, trying to manage side effects with cigarettes, sugar, and finally, fatigue and lack of motivation.
Yep, Yeah, those are all great things. Just as a side point on that, can the person who put in the stuff about cigarettes and managing symptoms, would the person who did that like to expand a little bit on that one? Because I came across some interesting reading when I was preparing for this, and it's a good opportunity to talk about it. If they want to unmute and talk, they're very welcome. Or put something in the chat.
That's Lisa from online. Are you able to add further to that, Lisa? While you're adding further, I will just read out some further comments from our online participants. Lower motivation to seek help and enact change, diagnostic overshadowing, less active, and Lisa has added poor housing, employment outcomes, family issues.
Those are all absolutely valid. Yeah. Has Lisa added anything more about the cigarettes?
She has.
Yeah,
My
good on
experiences of having addictive personality using coke, THC to reduce restless legs.
Yes, absolutely. It's interesting because when I was doing some reading on this, it appears that the cigarette companies actually put out a whole lot of research. And I remember reading some of this when I was younger, saying that if you smoked, you were less likely to get positive symptoms of schizophrenia. It's not actually true. Apparently, that's actually, who would trust a cigarette company? I'm going to say something controversial here. Helen, just hit me if I do. But, I believed it, hook, line and sinker when I was younger. Yes, it does do something for the akathisia, apparently. But it doesn't do anything when you look at the research. It doesn't do anything to reduce your symptoms, the positive symptoms or the negative symptoms of schizophrenia. So how important is that? We've got a whole lot of people who've been sold a pup around this stuff will help you with your mental health symptoms. And that's actually really not true and has affected a whole lot of people potentially who've been smoking to try and see if they could help with schizophrenia. That really makes me angry. So yes, we've talked about a whole lot of things there, and I think there's some really good points that have come up. Just moving on to the slides, because I jotted down a few things.
Jackie, before we move on,
Yes.
Jenny online has a
Oh,
question,
good. Yes.
and this is for
Please.
yourself or any of our panelists tonight who may be able to answer this. She made a comment that over 10 years ago, there was a large campaign around mental health and smoking. Has there been any change? Did government non-smoking in hospital impact this?
That is a really interesting question. The answer to that is I'm not sure. Chucks or Scott, have you got any information about that? Do you know of any?
I think in our population, probably the public health interventions that have occurred probably haven't been as effective, but also I guess the rising cost has maybe limited some. But the problem is that I guess our cohort might well choose to buy smokes over food sometimes.
Yeah,
I guess that becomes the problem. So I would say largely no. Those interventions haven't had the impact.
Yeah, what a shame. And I think that's the thing about public health is that when you're trying to get big effect sizes across a large population, that's not an easy thing to do because people are so individual, and not everybody responds in the same way. In the same way to an information campaign. So that makes sense to me. I hadn't noticed of my own patients, that there'd been a change, but so we've got work to do. We've absolutely got work to do. And that's not to say that we tell people to stop smoking if they want to continue smoking, of course not. But it is a question of going, okay, is this something that you've thought about? Is this something that we could facilitate? Can I help you with it? These are the reasons why it would be a good idea. Because sometimes people just don't necessarily have the context or the understanding of, and I'm thinking particularly of, you and I talked about this before the presentation, the gentlemen or the people that we see who have had amputations and have terrible diabetes, smoking, they don't have good access to healthcare, they tend to leave things late. And so much of that. We have the highest rate of amputations in South Australia in the whole country, and that's just awful. And you were talking about a patient of yours where that had actually been the cascade of things that had happened, I think, from memory. Am I right?
Yeah, I mean, that individual, it's amazing he's still alive. He's incredibly resilient, but and that probably highlights something that I was going to raise before, is that our patients are happy to see the psychiatrist, but don't want to do 2 appointments in a week or spread them out. So they don't often, we've got many patients who either don't think they need to go to a GP or are not well linked in. And, you know, one of the things that we try to do with our GP liaison nurse is build better links. I mean, in rural areas, everyone has to see the GP because the psychiatrist is in Adelaide. But in Adelaide, people have a choice, and they tend to, you know, there's a core of patients who are at very high risk that just see us. That's not the, you know, that's the reason for excess burden, health burden as well. So,
yeah.
So getting good link to GPs is critical.
It really is. And one of the things that I sometimes get asked as GP liaison is, can you help us find somebody who might be prepared to take this patient on? Because they need general practice, primary care. It's absolutely key to these people, because that's where you get a whole lot of these things sorted out. And you're right, if they haven't got access, if they haven't got somebody that they see regularly, a lot of things get missed. Thank you, Scott. If we move on to the next slide, because I'm just keeping an eye on the time.
Do you want to just unmute and add to your point before we go to the next slide, Chucks? Chucks, you had your hand up. Did you want to add something?
Please do.
Look, you know, from cardiovascular point of view, I think we sort of come in a bit late in terms of primary prevention with regards to cigarette smoking. So it is actually difficult for me to comment on the effect of healthcare awareness, what the effect is on primary prevention. But I must say that when patients come to us and have had a cardiac event, and we're looking at secondary prevention, we tend to get, you know, very good results, because most of them see their heart attack as wake-up calls, because of the rehabilitation program that is very strong. Most of them tend to stop smoking. But in terms of primary prevention, we don't usually get them. But they still do, but they don't tend to listen until they've had that shake in their lives.
Chucks, do you notice any difference if your person that you're looking after has a mental health condition versus if they don't? Does it seem to make any difference to how they'd respond to a heart attack?
How they respond to?
I'm just curious, really. I don't know the answer myself.
I think people with mental health issues, they tend to struggle a lot with regards to how they respond to all these other risk factors. There's a strong limitation in the way they respond. And, you know, I think there's also a bias from healthcare providers, because we tend to see them as much weaker, and you don't want to push too hard. You want to see if you can get a balance between their risk factors and their general well-being mentally. Again, in terms of seeing them, there's also a strong bias among physicians, I must say. When patients present initially, say, for example, somebody comes with chest pain, and you know the person has got a significant mental illness, they would tend to downplay the chest pain. You know, they tend to downplay the other symptoms. I think mental health explains everything. It must be anxiety. It must be anxiety. And that's a real danger, that we should keep. We should have a high index of suspicion that they also have a lot of physical illness, even just from the point of view that their mobility, their exercise regime is reduced. They are not physically active as the general population, so they're even at higher risk of developing cardiovascular events.
Thank you. That's actually very helpful for me. Scott, just on that, and Lisa, perhaps, anybody else who wants to chime in, but on that thought about people with mental health conditions trying to be softer because you're worried about making the mental health condition worse, How true is that? What do you think? And Michelle, I'd be interested in your take on this as well, if that's possible.
Look, yeah, and I think Michelle's the perfect person to ask. I'll hand the mic, but I think being upfront and honest and trying to get across, you know, pitching the information to the level of the person's education and understanding is important. But you know, at all opportunities, I'm trying to talk to my patients about physical health, you know, I think the message needs to be strong but fair and pitched. So I'll hand over to Michelle.
Thank you. I think it's really important from the start to try and get people involved and to try and find a way of breaking through to them and getting them involved. I mean, we all know what we should be doing, but participating in it or getting empowered to do it is the difficult thing.
Thank you, Michelle. I think that's absolutely right. We've got a kind of, I often think of it as listening to people and finding out what's important and trying to get alongside them, as opposed to being on the other side of the desk and lecturing. But yeah, I think that's so true, isn't it?
Yeah, true.
Yeah. Have you got any good tips for us of things that have worked particularly well when people have spoken to you about lifestyle changes?
My GP was really, really good with me because of the schizophrenia. I was really, really addicted to cigarettes, and he just kept trying and trying and trying with me, and eventually we got there. My psychiatrist has been brilliant around other lifestyle choices, like alcohol, and just reasoning with me and helping me to see how destructive it actually was and the influences it was having on me.
Thank you. It's actually really helpful to hear from your experience what was and wasn't useful. Because you know, if we don't listen to you, who are we going to listen to? You're the person who's most expert at this here, which is great. We've talked a lot about all of this already, and I'm curious again, Michelle. Sorry, I'm not deliberately focusing on you a lot, but I think it's helpful to hear. Did you find that people forgot to ask about physical health? Is that something that you encountered?
I've actually got that written in my speech. I do think a lot of GPs don't understand the importance of the physical health behind the mental health, and that they prioritise the mental health and then the physical health gets overlooked. And I think that is a serious problem.
Yeah, I'm glad to hear that. You know, I'm somewhere close to the mark, because that I know I've been guilty of. Sometimes it's all of the crises and the things that come up, and then you kind of think, you look at the notes and you think, oh shithers. I was going to say something ruder, but oh my goodness, that woman hasn't had a pap smear for 10 years. How did I manage to overlook that? And the answer is I've been focusing on a whole lot of other things. And I think what we've got on the slide here, and I was going to throw this open to the audience, but you know what, let's just talk about it, because again, I'm just very aware of the fact that I want to make sure that Michelle and Scott have got plenty of time to talk. Yeah, we just assume someone else is doing it. We just think, oh, someone else must be checking on this, or we forget, or you know, the people themselves forget. I think trust is often a big thing. Fear of, and I've had several patients where they've presented really late because they had a lump in their breast, but they were frightened of what it might turn out to be. Now that's true for anybody, but if you've had a background of trauma or you've had bad experiences with health professionals, then it's so understandable that people would come in late. And then of course that means that you've got not as good prognosis as you might have had otherwise. And then we've talked a little bit about the barriers that people have. Helen, I think, did we have one more? I can never remember how many slides I've got. What else have I got on my slideshow? Oh, what are we going to do about it? Oh, that's a good one. Okay, so what are we going to do about it? What do you think, guys? How are we going to fix this? Because, you know, world domination is always on the agenda. So, and we can't sit and do nothing. So what do we think are the answers to this?
We've got somebody here, Jackie.
Good. Go ahead.
I think sometimes it's important to understand their reasoning behind it. From my own perspective, working as an occupational therapist, I've had consumers who they don't actually enjoy the process of smoking, but the only thing that they can do from start to finish on their own is roll a cigarette. So they actually do it for the feeling of accomplishment and not actually for the smoking. So finding other ways for them to get that sense of accomplishment with more positive tasks, perhaps.
What a brilliant insight. That's something that I would not have thought of myself. Thank you so much for sharing that. And yeah, absolutely, I can see that that's just such a lovely example of understanding and listening.
Online,
Absolutely right. Yeah, yeah.
online, Jackie, we've got a more holistic approach and a second response, make it more visible in our services.
I love that. Yeah. How can we make it more visible in our services? Lisa Wilton, I am looking at you because I do.
You can't see me though, Jackie, on the other side of the room. Yes, well, we could make it a little bit more visible in our services. We know that there's the Equally Well challenge that's been put through to all of the states, and all of the states have signed up to that, and creating a mental health and physical health action plan within each LHN and getting everybody on board. There's a really fabulous example of that happening down in Salen at the moment, where Salen have taken on the Equally Well challenge. And they have their 4-point Equally Well action plan, and each area has chose one activity that they are actually doing within their services, and they're getting some good results. Slow going, it's a huge task, and as they say, how do you eat an elephant? One small bite at a time. So we just need to get some buy-in.
I knew you'd bring the elephant into it somewhere. I always love your elephants. I have to say, do you still have those beautiful posters? And we've been seeing examples of, I think we saw one at the very beginning of this, that we have on the Royal Adelaide television screens. Everybody needs a GP, and it's not just your head.
Yeah, we do. We do.
Yeah.
And I've still got plenty left. So yeah, so they've been sent out to all of the services. So it's advertised in all of the services that GP is part of the treating team, and we need to see that our mental health clinicians see that they're part of the treating team, but also that our GPs see that they are part of our treating team as well, so that it goes both ways. There's a really fabulous resource out there, Choice in Medication, which gives consumers access to really consumer-focused medication information that's freely available for GPs to utilise and mental health services to utilise and consumers to utilise through the SA Health webpage through there. So yes, we've still got all of those posters, and if anybody needs them, more than happy to send them out to you, even to GP practices. I will send them.
That's exactly what I was hoping you would say. And dumb question, if we got our posters onto the Royal Adelaide TV screens, could we potentially get them onto a GP's TV screens if the GP wanted us to do that?
Yes.
Hey, there you go. So
if they could do that, it would be their internal systems, because we do have the JPEGs that I can send them.
excellent. Well, there's nothing quite like having lots, and they are beautiful posters. And I think if we have those, and again, Michelle, I'm sorry, I'm going to pick on you again, but if your GP had something like that in their waiting room, would that make you think this person's someone I could talk to about these things? Oh, look, that's something I should actually talk to them about. Would it be useful?
I think so. I think it'd bring it to your attention and maybe trigger you asking questions about it and seeking some knowledge around it. If it concerns you, if you're smoking too much or you're obese or whatever your issue was. I think just understanding that the GP was available to talk about that kind of stuff with you would be a good thing.
Thank you. Yeah, good, because that's what I think too. So next slide.
Jackie, before we go to the next, I just want to read a few more comments from our online participants tonight. So I think we're making headway with this one comment from Scott. Greater education of mental health for GPs to access. Greater shared care between specialists.
Another comment here from Jeannie. Having worked in mental health inpatient, I am aware that the nursing staff have noted that they do not feel as confident with their general physical health, and that this means that in the hospital, I am aware that nursing staff have noted that they do not feel as confident with their general physical health, and this means that in the hospital this is a significant issue. And so think training in mental health staff in physical health will be important. This includes having appropriate meals in the hospital for people with mental health rather than recovering from physical health.
Those are great points. Yeah.
And final comment is, as mental health clinicians, we need to advocate for consumers with other health professionals involved at the pace that suits the consumer.
Yeah, that's such a good point. Don't push people faster than they can handle, but do talk about things that are important and find the balance correctly. Yeah, that's so true. Anything else? Any other pearls of wisdom? Nobody will go to the slides. Must be there's nothing else on the chat. So yeah, basically this is Jackie.
We've got one question, Jackie.
Yeah, I love questions. Go for it.
Hi, Jackie. It's Suha here. I've pestered you with messages before. You've previously worked in private general practice, so just hearing all of these comments today, how do you feel that's going to work in terms of trying to make it more patient-centered and trying to go at that pace and trying to be more holistic, knowing that, you know, that a lot of us know all of this, but the reality is much harder?
I absolutely get what you're saying. Yeah, it's not easy in general practice because, you know, I can say book longer appointments, and we all know that that is not as easy as it sounds. I think it's almost like having a little reminder on your desk. Don't forget the physical stuff, because I think, you know, when I think about the patients I've looked after, and I look after a lot of people with mental health conditions because I love mental health. It's something I really enjoy looking after. It's kind of doing that little automatic audit in your head of going, have I checked this person's blood pressure? Have I done a pap smear? Have I done any of the preventive things? Have I done their lipids? And actually, when I think about it, some of the best situations have been when it has been somebody who's having shared care through one of the mental health teams. And I can think of one in particular through the Southern mental health team, where I had the most marvellous handover from the team. And it absolutely jogged my memory to do all of these things. It was so useful. I think the answer is not easy, but I think if we're going to do the right thing by our patients, we've got to find those opportunities. And you don't have to do it all in one glorious hit. That's the other thing. You can say to the person, look, we can't deal with everything today, but I do want to do your blood pressure. And then if it comes back and their blood pressure is really high, you might say, look, come on, we've got to actually start doing something about this. I can't do it today, but can you come back a bit later in the week? Because this is really important. And then we can talk about what you can do about your blood pressure. And by the way, we might just get you to do some lipids. Can you skip off of this form and go and get those checked? Because you really matter to me. And I want to make this, I want to try and help you as much as I possibly can. Does that sound realistic to you? And be honest. You can tell me I'm being an idiot. It's okay. I can cope with that.
I'll just make a comment in passing. This is where NDIS is critical, having the support to bring people in.
Yes. Yes, I'd agree with that.
In my delusional thinking, I would love to fund social workers in every general practice. I would love to have nurse time actually remunerated, because I work with a lot of non-English speaking people with lots of chronic pain and mental health, and I do most of the stuff out of hours. I could barely make it tonight because most of that stuff, the medical stuff you're trying to do out of hours, because they don't want to talk to you about that because you want to deal with their issues first, but it's just cumulative problems that happen. So if they could have a nurse call them, you know, and do it in their own space, in their own time, we might have a bit of better chance, but I don't know. Just thoughts. But yeah, I think that utilizing other resources around us, because unfortunately the private GP model isn't working. We just can't fit everything in, and it's just getting harder and harder. We're best placed to do a lot of things. And so I know that a lot of the other stuff fails and we feel really bad about it, but I don't know how to do anymore. And it's really going to be very hard for people to find general practitioners now because people are leaving.
Yes, I think I love the idea of a social worker in general practices. Trust me, I'm talking to the PHN about these sorts of things. Anything that we can get that improves the ability, and practice nurses are one way. If you've got a good practice nurse, sometimes they can take on some of that work, but I know it's not easy. It's not easy. And I sympathise. As a GP of 31 years experience, it's not easy out there. But we kind of have to do some, even if it's just a little bit at a time. It's not easy. I don't have any clever magic solutions. Anybody in the audience who does have clever magic solutions, please put your hand up and give them to us, because that would be very nice. But I do think it's important that we do say to people, look, this stuff does matter, because I don't want them dying 15 years earlier than they should have done. That's just awful. We need to close the gap for mental health. And yeah, it's so important. And I do think some of the things I've said in here, teaching the person themselves, telling their friends and families, these are really important things to make sure that you do. And not just doing the screening, but actually doing something about it, because it's very easy to get stuck in a rut and not get on with the things that you need to do. I think it's that balance, isn't it, of saying, this is important, we need to do something about it, but the person themselves saying, well, I don't want to do something about it. So it's the art of medicine. It's what Nicholas Farinola in our service calls the soft skills. And I just look at him and I think they're actually the really important skills. Scott, you got any tips or hints? Chucks, anybody want to throw anything into the mix here?
I just think from a service perspective, communication is critical. So trying to make sure that decisions are shared with GPs by phone rather than by kind of disconnected letter. I encourage staff as part of my reviews to make sure you contact the GP. You can save a lot of errors and time at the GP end, and I guess, as I said, the NDIS or some sort of social supports for patients that can't make it there. And we've started involving lived experience people to have discussions with people about their mental health, about their physical health. So I think those three things may be critical. I'm not sure, Chucks, you were talking about the fact that once people have an event, they are willing to engage. Is there anything else that you can think of?
Well, I think in addition to that, look, I actually enjoy this meeting, and I think creating this sort of awareness among GPs and other specialists is very, very important. And having that willingness to, consider more of holistic medicine. If we look at a patient as a whole and remind ourselves that both mental health and physical health, they feed into each other. And if one aspect is not functioning well, it will have a bad effect on the other one. If, the physical health, we might even improve the mental health to some extent and vice versa. So I think having that high index of suspicion when we see patients with mental health, to look into their physical is very important, and creating the awareness among other specialists.
Thank you, Chucks. It was occurring to me as you were talking, Scott, if we as GPs have a patient with us where we're struggling and there are some important things that we want them to take on board, but it's a time thing, could we then ring the mental health service that they're being shared with and say, hey, listen, I'm trying to get this person to stop smoking. Any chance that you could have a bit of a chat to them? And is there anything that you can do to facilitate that? I mean, I know you haven't got a magic wand in your back pocket, but if we worked together, if everybody was on the same page about that, would that help, do you think?
Look, I'm very happy to get calls from GPs. I mean, in the workflow, it's a busy day. I'm only there on Tuesdays. but I will, respond. And I've managed some very, very complex people with sort of medical conditions, and it's great to have the GP backup for that. I mean, I ran a clinic with Peter Donohoe for nearly 10 years, going out and sitting in the clinic, and we shared a lot of difficult patients. So it's it really works, and there's no other way that you can actually fully holistically manage these people. And look, I fully acknowledge the problems with the GP model of care. Declarations, my wife's a GP, so it's the business model is not there anymore. And so, I guess getting together groups and lobbying for better integration and for the sort of funding and support in the model to do that is something that can come out of these sort of discussions.
Thank you. And it occurred to me as well as we were talking that organisations like Skylight, I mean, I know it's short-term stuff, it's 3 months usually, but if they can assist a patient to get to the GP, that's another possibility. And I think there are some practices in the north, and I'd better just check, but I think they still do have some Aboriginal health practitioners in a couple of practices in the north, and I'll check and get those details from Adelaide Primary Health Network. And then perhaps we can send that out as part of all of this, and the Skylight details as well. Look, it all helps, anything that we can do together. And just so that people know as well, there's a mental health liaison, at least you can tell people about this if you like, mental health liaisons at both Eastern and Western Community Mental Health, right?
Yes, there is. Well, we might, Jackie, skip through to Michelle's presentation now.
Yeah,
we're going to come back to your tips.
I love it.
We've just got one comment while Michelle's getting herself ready.
Yep.
Hi, my name's Deanne. I'm from a community mental health program called Diamond House. We're a psychosocial day group program for people with mental health. And just listening to, because I assume the most of the room is clinicians, we're not clinicians, we are support workers. I am a qualified and registered counsellor as well, and I work a little bit differently than most counsellors. I work somatically, so I am looking at the holistic whole approach of a person, both a physical, mental, psychological, spiritual, emotional well-being. And we do that at Diamond House as well. So we work within a wellness plan and we support those people. Just from my own just perspective is I think the problem with mental health is that we all sit in silos, whether that's clinicians or whether what we do. We don't talk to each other. And that is the biggest problem I find in this field. And I find it extremely frustrating, and I know that other colleagues do too. So we're meant to be here for the client. So it's about what the client wants and needs. And yes, we need to look at that holistic approach. So when we're talking about things like, the clinicians, you guys are great at what you do, but what happens at the end when they walk out the door? And that's where we come in. We support these people past you. And it is about what we do. We're one of the very few, there's only 2 in South Australia that do not have an end date with their clients. We're one and Grow is the other. Everybody else has an end date with their client. And we are now getting inundated with people because we know that funding is coming up for renewal. And so where are all these people going to go? You're talking about NDIS. That's 20% of people with mental health. Where are the rest of these people going? Where are the rest of their supports? So I feel it's really important that we all actually get together and we all actually talk about how we can help these people support each other holistically. So
thanks. Yeah, that's a really good point.
It certainly is. Thank you. I've got to hand over to Michelle now. Thank you.
Can you hear me? Yeah. Well, my name is Michelle Quirk and I have been prescribed clozapine for approximately 30 years, and I have a diagnosis of paranoid schizophrenia. For a long time now, I've been cared for under the Shared Care program. I will begin by talking about Shared Care. Being transferred to the Shared Care Management Program has been a good change in the management of my care, as it has provided me with more independence and autonomy in my treatment. I've needed to be more organised and independent whilst on Shared Care. I'm a firm believer that for treatment to be truly effective, the individual needs to be involved. Shared Care lends itself to this philosophy. When under shared care, it is important for all members of the team to have open and frank communication. If the consumer has concerns, they need to feel comfortable in approaching their team. In the past, I have felt judged or misunderstood, and this hinders my ability to communicate with the individuals I work with. My GP and mental health service are required at times to communicate with each other. This is usually accomplished by either email or letter. For example, when my psychiatrist decides to monitor something or change my dose, this will be communicated to my GP. Additionally, the nurses that form my clozapine coordination team will sometimes request that I have a fasting blood if they have concerns, and they will email me a blood request form. When placed on the shared care program, one has access to a coordinator, a psychiatrist, and their GP. The responsibility of supporting an individual is shared between each of these individuals. It affords the consumer a wide range of expertise upon which to rely on, the GP being the individual that the consumer sees the most often. It is important that the consumer feels able to discuss any issues with the GP without judgment, and that what they share be respected and adhered to. My former GP, who has now retired, made a significant contribution to my quitting cigarettes. This in turn affected the effects of my clozapine dose and had a rippling effect because I then had more money, more energy, and more confidence in what I could achieve. Gentle encouragement from a treating team is required when addressing physical health. When one has a mental health issue, you often feel that you are a failure and therefore lack self-esteem. I have discovered that if the physical aspects of your treatment are encouraged, it can truly make a big difference to your self-worth. Whether it be encouragement to exercise or diet or quit cigarettes or to cease substance abuse. For me, I had gained 35 kilos when placed on the medication I was prescribed, clozapine. Eventually, the medication assisted me to become well enough to address my weight issues. It felt amazing for me to succeed at something, and my success encouraged me to continue my weight loss journey. Improving my physical health had an immense influence on my dealing with my mental illness. I felt empowered and felt that I had some control back in my life. It brought my confidence up to greater heights, and with that, I realised I could succeed at more in my existence than I had formerly believed. Unfortunately, not all GPs are receptive to mental health issues. I know of consumers in the mental health system that have complained of physical symptoms to their GP, and this has been put down to being related to their mental illness rather than anything else. Often, physical aspects of an individual with a mental health diagnosis may be overlooked as less important than their mental health problems. I believe that concerns about one's physical health should be respected and supported by the GP involved in their care. It is vastly important that individuals with mental health be able to confide and discuss issues like this with their treatment team. It is hoped that they don't feel judged or treated as a lesser human being just because they have a mental illness. My psychiatrist has had a huge effect on the amount of alcohol I consume. She's been truly supportive in this area, and my quitting drinking impacted on my existence considerably. As you would all be aware, the abuse of substances is rife amongst those suffering a mental illness. In the short term, the substance provides relief for the individual, but the negative impact is significant. Individuals with mental illness are already more vulnerable to the effects of these substances due to their state of mind. It is the truth that it is a sad fact that individuals with a mental health diagnosis, me included, want to numb or change the way they're feeling by altering their mindset by using different various methods. Living with mental health issues is difficult, and individuals require often significant support to navigate their existence without turning to an avenue of escape. Substance abuse is so significant amongst consumers because life is so very difficult. Many individuals have no chance of gaining employment or of purchasing a property or embarking on the life that so many individuals take for granted. Life is boring and mundane without the opportunity to stretch oneself or join in mainstream society. And the friends one makes that genuinely want to be around somebody with a serious mental illness are often those who fall into the same section of society and can then influence the individual quite badly. It is a sad fact that the only enjoyment in life one feels when seriously unwell comes from cigarettes, food or other substances, which may not be healthy in a physical sense for the individual. I partook in all of these things until the medication clozapine assisted in improving my mental state. I feel that the medication has saved my life. However, there are side effects to all medications, which is prescribed to an individual suffering a mental illness, and the combination of bad habits and medication can be significant. Often the combination causes physical illness and general bad health. Currently, it is wonderful that there is a focus on looking after those with a mental illness's physical health as well. Of particular significance is the Equally Well project, which is currently occurring in Sarlan. At my place of employment, the Trevor Parry Centre, we've put together a varied team, OT, RN, CRW and lived experience worker, to attempt to implement various projects by which to assist consumers to focus more on their physical health. At the moment, we're considering the implementation of certain groups and one-to-one support with consumers that are either interested or require assistance to be supported to address their physical health. In the future, I hope that GPs can assist individuals to be assessed by dietitians or other professionals. It would be amazing to see consumers supported in the community by workers to shop for healthy groceries. Additionally, I hope that support is provided to assist people in knowing how to feed or cook for themselves healthily. I believe the development of these basic skills is vastly important, as many individuals do not understand how to care for themselves well. Often support is required to assist the individual to look after the basics, healthy food, etc., in their care. In my case, I was very lucky. I had a very supportive family. I confided to my father that I wanted to lose weight. I needed to because although clozapine had helped my mental state, physically I had gained weight to the point that I almost weighed 100 kilos. My father paid for me to attend a women's weight loss centre, Healthy Inspirations. They placed me on a diet and gave me a weekly exercise routine. Every week they weighed me 3 times. The most beneficial aspect of the service they provided was the one-to-one counselling. I could discuss and work through any difficulties that I was having with one of the workers. It was incredibly supportive and helped me to understand that I am just like everyone else in society. I face the same difficulties in managing to look after my health as the rest of society. It is wonderful to see the focus that is occurring on the physical health of individuals suffering mental illness. I believe that improving the physical health of individuals impacts significantly on their mental health. It is not only helping to hopefully make people live longer, but it will influence the state of their mind and their ability to manage their mental health. Having goals and a routine to focus on truly improved how my auditory hallucinations affected my life. My physical health directly impacted my mental health. This highlights to me the significance of treatment teams supporting individuals to address their physical health as much as providing support to cope with their mental health issues. The lack of funds to purchase gym memberships and other expensive products, which other individuals in society purchase to help them with their physical health, are beyond the reach of many individuals on government benefits. This highlights the importance of treating teams, researching and linking individuals in with workout groups, cooking groups, and other services and approaches which individuals can access, which may help them improve their mental health. I am very grateful that my GP every month takes my blood pressure and weighs me and helps me to keep track of how my general physical health is tracking. I have regular fasting bloods which test for various things that may be happening. It is a beneficial part of my care that I am assessed so regularly. This may be more often than the general population's physical health is checked or assessed. The close monitoring of my health assists my treatment team in becoming aware if anything of concern is occurring and enables care and attention to be given to any problems that surface. With myself recently, my blood test revealed that my sugar levels were high. I spoke to my psychiatrist about this issue and she immediately placed me on a medication that will assist me in not developing a significant illness such as diabetes. Unfortunately, mental health medications can often lead individuals to tending to develop some serious illness. However, it is fortunate that due to their mental health care that they are given, that any problems can be identified earlier than many other individuals in society may become aware of an illness occurring to them. I am truly grateful for all the support and care that has been given to me over the years. I've lost friends to physical diseases, such as cancer from smoking cigarettes, over the years that have had the same diagnosis as me. It is sad that individuals don't seem to realise the implications of not giving more attention to their physical health, and that individuals are so vulnerable to addictions and maladaptive habits which can cause serious health problems. I have confidence that there is now more attention being paid to the importance of physical health in consumers, and that their treatment teams are aware of the significance of their support in this area. Thank you for listening today. It is important to me that professionals are interested in the fact that this is a serious issue and recognise that it is very important to address it in the care of consumers. I appreciate the opportunity to convey my experience in the health system and the reasons I believe that my mental health has so vastly improved. Thank you for your time and your attention.
Thanks so much, Michelle. I mean, your story is a very important one, and I've had the pleasure of working with you over a number of years, and you've made such a great impact on the health service with all your input to the committees and everything else. So thank you very much, and thank you for sharing that today. We can see that physical health is a critical component, and Michelle's also talked about, you know, having something to do, having meaning, having, you know, working towards recovery, and these things are all critical. And you can't do that without, you know, you need your physical health and you need your mental health, and then you need something to do a lot of the time. And if you can fix those things, then life's, you know, apart from all the things that happen, it is a lot more simple. But, and I guess, to segue slightly, what I'm going to talk about here is go through a case looking at how we make decisions right from the word go, from a first presentation leading up to clozapine treatment. And this case, Chuck's has actually helped me manage, as you know, it's quite a complex case, but it gives us a chance to look at how we can make some good decisions in terms of treatment and engage the person. And this is a great example of collaboration with GP, but especially with specialists. So it's not just psychiatrists and GPs collaborating, mental health services and GPs, it's actually us collaborating with other specialists as well. We've sort of many text messages and many emails with this complex case towards the end. So I'll skip through. So we're going to talk about a 17-year-old gentleman who's, I guess, before I first started taking care of him, had a fairly tumultuous course, Sri Lankan origins, history of trauma in the past, mother had passed away, family migrated as refugees to Australia. And I guess lots going on for this individual. I guess on top of that has to put up with developing a psychotic illness. And so this is a common sort of presentation with people with, I guess, a prodrome leaving in schizophrenia. There's tailing off of school performance, things aren't quite going right, odd things starting happening at home. There's often sort of conflict at home and a lot of distress around there. There might be some occasional drug use, occasional alcohol abuse, but people's performance tend to drop off, they don't achieve. And the patient then turns up to the GP with the father in this case about odd behaviours, staying up all night, yelling at others when no one's around, conflict over strange ideas. So what parts of assessment do people think are critical here? What would you do with this person? Yeah.
So I want to know like a little bit more detail about. I want to know a bit more detail about the drug use, just to quantify how much that is and figure out if that could be part of the story. I'd also want to try and rule out any organic cause of his behaviour. So that's where I'd start.
Those are important things. I mean, how comfortable are GPs at asking people to do a urine drug screen as part of a consult? It's tricky. I mean, we use them all the time in emergency, but actually understanding what the nature of that problem is important. Is it anyone else want to add?
Online, we've got all of it.
All of it?
All of it online.
I guess you need to understand a bit more about the family history, and you need to collect the history of the presenting complaint, work out how concerning these behaviours are, what risk behaviours, trying to get a better idea for what the actual strange behaviour is. Have they seen him talking to people? Are there any other odd things going on? And also risk assessment, what sort of dangerous behaviours might be happening. And I guess you really want to then see the patient, don't you? You want to get in and do an assessment. And so you get him into the clinic and talking, and I guess this is some of the history that you get him into the clinic and interview him, and you get a history that there's some auditory hallucinations, some ideas of reference, getting messages from the TV and the radio, worried about what that means. So there's some sort of more kind of grandiose, paranoid meaning behind it. There's some sort of conspiracy. And on occasion, there's been irritability and risk. You want to ask about suicidality, so you want to make sure that you manage that risk, and you want to assess for depressed mood as well. And so putting these things all together, you actually think that you're not quite sure about the length of that it's gone on. So for a diagnosis of schizophreniform disorder, it's 3 months. Of symptoms sort of much of the time, for at least a solid month. And schizophrenia, you need actually 6 months of symptoms. And you're never quite sure, are the symptoms there when the drug use is going on or not? And these are the things that we face when we're assessing someone for the first time. So it's probably a first episode psychosis. You could call it a schizophreniform disorder because maybe it's gone over 3 months, but you don't really know if this is schizophrenia. So what else do we need to do? Apart from call a psychiatrist. Yeah.
Maybe understand how the person wants to be handled when they're in an unwell state. So understanding if something were to go wrong, who they'd want to be contacted, ensuring that what they need is central to the care.
Yeah, and I guess sort of understanding the family dynamics behind that as well. So sometimes there's sort of hostile codependent relationships, and that's very tricky. But sometimes you want to engage with the family that's engaged and is supportive, and trying to work out how best to sort of broker that deal and how much information they're happy to share. That's important. Yeah. Anything else?
Online, we've got routine bloods and baseline ECG.
Yeah, well, routine bloods, I mean, you want to screen out any organic conditions. A baseline ECG is useful for measuring sort of QT, and because most of the antipsychotics that you'll start can link to QT. Some are worse than others, things like ziprasidone and amisulpride, and some are not so bad, but getting a baseline
and also what interventions have occurred to date.
Understanding if the patient's had medications in the past, understanding how they've responded, whether they've had side effects, all those things are important. So what would your management plan include? What would you do at this point? So trauma, understanding, and trauma is tricky. I mean, you don't want to open up a box of worms, but you want to understand if there are features of PTSD. I mean, this person's come from a war-torn country where there's been a lot of violence. How's that impacting? And I know I've had patients where a significant part of it's trauma, and the psychotic experiences themselves are traumatic. So actually picking apart some of that in a safe way where the person feels okay to talk about that is a reasonable thing to do.
I think Jackie put something up.
We've got, Jackie, you've got your...
I did. I also want to know if there's a family history of any mental health conditions, because my daughter, who's a social worker, has just had exactly the same experience with a kid that she's looking after, and a strong family history of schizophrenia. And bingo. Yeah, exactly.
So I guess the sort of biological risk factors, like having a history of sort of any mental illness, but I mean that increases, doesn't necessarily mean that the person's going to get schizophrenia, but it increases the risk definitely. So it all comes together to get your picture.
I've got a couple more comments online. How often are psychotic symptoms dismissed as drug-induced rather than explore further symptomatology?
how often do people commence drug use to self-manage their symptoms? And then another comment, engage the client as much as possible in care, but also key stakeholders such as family.
Yeah, and look, every weekend, if you go into any emergency department, there'll be someone who has a brief psychotic episode, and then it depends on how well they settle, whether they go home and the risk around them, and whether they can get good follow-up. So, but it's really hard. You know, one of the hardest calls is if someone's taking drugs all the time, is that schizophrenia or is it just repeated drug-induced psychosis? So that's really tough to understand. But I guess you have to try and help people engage in abstinence and harm minimisation practices so that you can actually see. So it's tricky, and often people end up on antipsychotics anyway. So I'm just mindful of time. I mean, what you've talked through, I mean, this is what we present to medical students we teach these days, well, the last 10 years, since I've been there anyway. So we're talking about picking out the diagnostic category by the symptoms, and we've talked about, you know, the patient has some psychotic symptoms. We're thinking about what are the emergencies, what's the risk in terms of what's going on in the patient's life, the decisions they're making, are they floridly psychotic in front of you? And then, you know, intervening, is there an organic component, making sure that, you know, there's, you've screened for, you know, a delirium secondary to in a younger person, you've still got to be aware of, you know, basic delirium screen. If someone looks like they're kind of confused, if their attention's impaired, if they're disorientated, then you've got to think, well, first, you know, this might be a delirium. And, you know, we encourage, particularly in emergency departments, for that to be done more regularly because we often come across them. So you gather some history, and you might have notes where you gather history from the family, and then you talk to the patient, and you're trying to match that history to the signs and symptoms of the disorder. And then you're increasing or decreasing your probability of disorder. You do a mental state, so you're trying to pick the features. Do you see the person responding to stimuli? Are they talking about hallucinations? Do they look dishevelled? You're building up a picture. The further investigations, and then you do a management plan. And in formulating the case, you think about what's happened in the past. We've talked about some of those things. What's happened right now, the precipitating factors. What are the perpetuating factors? Ongoing drug use, poor medication adherence, you know, no social supports. And what are the positive factors? So the protective factors. So this person had good function previously. They've got a supportive family. They've got an easy personality, and you can engage them. So you need to think about all those things when you're assessing someone and bring it all together. So these are recommendations for screening in the e-therapeutic guidelines. So, so there's a range of organic considerations there, and this is easy access. I won't bother to go through all of these, but they pretty much follow what I've presented there, but talk about specific screening. And ECG is good for, you know, making sure that there's that the QTC is appropriate. And also thinking about brain imaging, very low pickup rate. There's a lot of argument whether this is useful or not, but for someone with the first presentation of psychosis and it looks organic, I mean, definitely if there's neurological signs, thinking about ordering a CT is important. And then broader screening as appropriate. So, oops, need to go back a couple there. So baseline measures to make sure that you're identifying issues with metabolic syndrome and identifying change. So if you take them at the first presentation, then when you start medications, you're going to be able to track those things. So these are all critical parts of managing someone's physical care, but also, you know, they're an important way of, I guess, engaging with a person in their physical health from the word go. So teaching them about the, you know, the potential side effects of medications, or teaching them about their physical health and engaging them not only on the mental health level, but on a physical level as well. This table took me many hours to assemble, me and I guess a group of experts. The information in this table is hard to process. Antipsychotics have a wide range of receptor binding profiles, and they have, so as part of the management plan here, I'm saying you might choose to start an antipsychotic. The recent meta-analyses show that largely antipsychotics, apart from clozapine, are relatively the same in their efficacy. there are many schizophrenias with many different mechanisms, and different people will respond better to different drugs. Some are more sedating, like olanzapine and of course clozapine, and we use them very heavily in acute situations to basically for sedation initially, and you get the antipsychotic effect. Often in hospital, patients are put on relatively high doses to control, to settle them down, and they may not need the same dose longitudinally. The thing is, though, you've got to be very careful about that. And there are studies now going at looking at dose tapering and getting the dose right past discharge. So I'm involved in an international group that's looking at that. Again, it's tricky. You want to get some input from a psychiatrist around those things if you can. But sedation and extrapyramidal side effects and weight gain with drugs like olanzapine can be significant post-discharge, and actually getting that right to get the cognitive function and function right is critical. The partial antagonists like aripiprazole, like cariprazine, brexpiprazole, the newer agents that are out, maybe the data suggests that they're slightly less effective on the whole, but they work quite well for people that they work for. And they're probably worth a go first up because they've got the best metabolic profile. So not to say that people won't gain weight, but they'll be less sedated and probably more easy to engage on that level. It just depends if the person in front of you is agitated, is not sleeping, needs some sedation up front, and that might determine the choice. I mean, I think people in general are pretty comfortable with olanzapine these days. But the problem with olanzapine is it's got, next to clozapine, one of the worst long-term profiles in terms of metabolic syndrome. And risperidone and paliperidone are kind of in similar zones. We have injectable, long-acting injectable forms of all these drugs now. And so making a choice is not so much thinking about, well, I'm worried about adherence with this patient, so I'm going to start him on something that I might be able to use as a long-acting depot medication. But those, that's not the case with these medications now. So actually picking a drug that is going to put on the least weight, it's going to be the least sedating. If you need sedation for short times, you can use benzos. We don't do this well in the hospital system yet either, I think, because we use olanzapine in the ED, it tends to flow on from there. But having a think about using some of these less sedating agents with some sedation support initially is reasonable. And again, when you've got patients in front of you, whether you can manage them or not, it's really down to the risk. So is this patient too sort of dangerous to themselves or others? Do they need mental health input early? And then trying to make a good case for that, making a good referral to the community team, or if there's an emergency, calling through, it is, sometimes a challenge. But if you've done, if you work through all of this information and you can summarise that and provide it, the mental health team will understand, that risk a bit better. Just mindful of time. So it's complicated. So in terms of monitoring for adverse events, this is the therapeutic guidelines recommended schedule. So programming this in to get people back, and again, GP clinics trying to have a model of care in the current environment. I'm not sure how it all works anymore. But these are the sort of key points where you want to get people back and try to intervene. And for clozapine, we see people weekly then monthly for the term that they're on it, and we're monitoring these things all the time. We just don't do a very good job of doing anything about it much of the time, unfortunately. So there are good guidelines out there for how often you should see these people and assess them. So you can commence, Dylan, on oral aripiprazole and refer him to a private psychiatrist. I'm probably being generous saying he will see him in 3 months' time. So that's about right, I guess. And you review them the next week because you want to see about the early effects of medications. So the one thing about partial agonists is people can get restless. That's probably the worst side effect. And the management of that restlessness is really about sort of dose adjustment, or if they can't tolerate it, it's actually changing to a full agonist. Or you can use things like beta blockers, but it gets fairly specialist and you want some input around that there. The restlessness can sort of go on for, like most medications, can last for a few weeks and settle down, but if it becomes problematic, then you might need to think about another agent. So he's concerned the medication makes him drowsy and his psychotic symptoms have not improved. So what do you do? So one of these things. So do I click forward or is it?
Just give it a moment
Thanks.
so everyone can just have a moment to get their phones out and scan it. The QR is on the next screen, but it will have moved. So
Okay.
looks like everyone's had a chance here to scan it. We could probably go to the,
To the next
maybe some in the, hang on, some in the front.
All good? Okay, let's see.
There is a QR code there in the corner. If you haven't managed to scan it just yet, on the corner of this screen, it does have the code there as well.
So look, it's still flickering a bit. We won't take too long. We're under a bit of time pressure now. So, I mean, you could move the dose to the evening with a partial agonist, but they're a bit alerting, and that's worked in some cases. And obviously putting sedation at night is much more practical in terms of function, and particularly with drugs like clozapine. When I changed around dosing, moved it all to the evening, taken away people's morning doses, they're on split doses. I've had patients that have gone back to work and now I can't find them. You know, they don't come in on monitoring days. That's the biggest problem, which is good but bad. It's great that there's one person I'm thinking about that's really hard to find, but he's doing really well. It's only because he's doing really well. So there's that issue. You can try that, but it might be a bit, even though they're sedating, it might also, if they're restless, that might not work. I mean, wait and watch is a reasonable thing, and it depends on how severe it is. And the other thing you could do is just short-term. I mean, he's more worried about sedation. So if he was restless, you might have a short-term benzo. You probably, you know, within a week, you wouldn't change the antipsychotic unless the effects were really severe. So you want to give someone, you know, a good 4 to 6 weeks at a reasonable dose to before you change. So Dylan agrees to continue with the current dose and review next week. And he presents 1 week later as restless, states he doesn't like the side effects, but is willing to persist, reports regular hallucinations and vague ideas of someone causing these, but no plan to act. What do you do next? So he's now got the restlessness problem. Sorry? Oh, yeah, sorry. All good? Still flicking. Look, it's still only 2 weeks. You could wait and watch. You could reduce the dose. Moving the dose to evening is not going to help the restlessness. Probably still, unless it's really distressing, too early to change the antipsychotic. Although aripiprazole is probably, you know, well, partial agonists are the worst. It's their worst side effect. It's not necessarily the worst of all the antipsychotics. Changing to another one doesn't necessarily mean you'll get improvement, but it's an option. So I think in this case, the other problem here is this person's not fully responding to medication. And I think while you probably persist a little bit longer, if you're finding sort of to 4 to 6 weeks that you're not getting full response, then you really want to start to think about changing. And you could change to another agent like, I guess, risperidone or paliperidone, more likely to have extrapyramidal side effects in terms of tremors and less likely akathisia, but you may still strike trouble. So I think it still might be a little bit early, but it's reasonable to consider. Reducing the dose is probably, it might be the first, reducing the dose won't help with the breakthrough symptoms as well. So you know, changing or waiting and watching further is probably reasonable approaches there. So again, it also depends on the risk. So patient doesn't turn up next appointment, lost contact with the family, hasn't been home for several days, left in his car, and then you get a notification that the patient was admitted to ED, is involved in a road rage incident, we rammed the car in front of him. So quite concerning, risky behaviour. And the police have brought him into ED and he's agitated, he's reporting delusions. He seems to be responding to internal stimuli. He accepts a moral PRN, which is good, because we don't like people to get agitated and we have to take things further. We shouldn't have to take things further. He's not agreeable to hospital admission, and so he's under an ITO, a place for admissions award. So what do we do now with his management, his treatment? What do we have to think about? Yeah, whether he's adherent, and you can do aripiprazole levels, but you can look at packets and you can do a bit of forensic investigation around that.
Ruth?
Yeah, in terms of we have to understand this behaviour, get some more information from SAPOL.
Online, we've got a couple of comments. Try another antipsychotic or seek collateral.
Yeah. So all these options, and potentially you've got to ask the patient, are they not taking the antipsychotic because they can't tolerate the side effects? And so then you have to swap them onto something else. Really, they're just not going to take it. Also, you need to think about, well, if this patient's not going to take antipsychotics at all, then do we need to think about long-acting formulations? But it's really about engaging the patient, going back to that structured model and working through all the things again. You know, has there been drug use? Is there any other organic condition? How's the patient presenting? Working all through all those features again. And so another thing is, you can increase the dose of aripiprazole. Patients, when they're admitted to the hospital, to the wards, they generally have standard PRN orders, and so they get PRN olanzapine and oral and IM, lorazepam or oral and clonazepam or midazolam IM for any agitated behaviour. You've done some organic screens, and they're all negative. He's UDS negative. And so for the next 3 weeks, you push aripiprazole up to try and get the maximum effect. I guess the restlessness at this point wasn't assessed as being too strong initially, but lo and behold, he actually does get more restless. And this is really the point where he's not responding to a medication and he's got some side effects. It's really time to switch it over. So what are the treatment options now? I don't think I've got another scan for this.
No. Would anyone like to add anything? Those online?
What drug option might I choose? What might I change to? Sorry?
Let's go clozapine.
It's still probably a bit early. So paliperidone, we can probably skip through in terms of interest of time. But then we've gone for a new drug and we've titrated to 6 milligrams. In terms of hallucinations, it's worked. His agitation resolved. He's got some residual delusions, because delusions always hang around longer than hallucinations in terms of the positive symptoms, because delusions are, to some extent, people trying to make sense of what's happened to them. So it takes, people get those ideas and it takes longer for them to resolve, if they do. Discharge home with family. Attend your clinic again the week after discharge. He's still too drowsy. He can't hold a cup properly. So he's got tremors. And he's also got sexual dysfunction, doesn't want to take medications, doesn't want to maintain with the health team. So what sort of things do we need to assess at this point, and what are the options? No one?
I'm just waiting to see if there's anyone online. We did have 2 online who did select paliperidone. Yeah. So we've got reassess risk.
Yep. And so I guess as part of the assessment, you want to check if he's actually taken the paliperidone, if the levels are dropped. He's now had 2 antipsychotics, so you start thinking about clozapine, but there's one point in between, which you talked about previously, and that's trying an LAI. I guess at this point, if he's getting lots of side effects, starting down the LAI route is not the greatest thing. Sometimes people go down it as well, but it might be the time to call on clozapine now, because you've got resistance on both, on at least 2 medications. And then he gets admitted again. He's now on an open ward. We'll skip through a bit because we're running out of time. Trial of our IM paliperidone. Because we're not really sure if he's actually been adherent, you can take levels, but people can load. Sometimes at least a trial of a LAI is indicated, and that's part of the treatment-resistant psychiatric schizophrenia guidelines now. You can manage EPSEs with benztropine, but that adds cholinergic burden, and it's not great to add medication on medication. But if there's no other option, and remember that people have to want to take clozapine and have to comply with the monitoring. So we'll just skip through it again. So this is the criteria for treatment-resistant schizophrenia. So we need to consider, 2 treatment trials, but at a reasonable dose. So they need to be a dose that's high enough in terms of their equivalence to chlorpromazine, but a solid dose of paliperidone like 6 milligrams or aripiprazole like 30 milligrams, you've kind of gone to the upper end of the dose range. If there's adherence, and sometimes that's hard to check, potentially the optimal criteria would be a depot trial, but that's not always the case that's carried out. So we move on to clozapine. So because clozapine has low D2 binding, so all of our antipsychotics work through D2 antagonism, it's better for EPSEs. It's actually the best drug to manage people with Parkinson's who need all the dopamine they can get. The only other drug that's kind of has that weak binding is quetiapine, but clozapine is actually the best. But we need to consider the patient's history. We know that 30% of people respond to clozapine and nothing else, but we need to screen broadly for blood dyscrasias. We need to check for cardiac issues, and this is where Chuck's came in and was very, very helpful down the track once we started having some problems. And full screen in terms of ECG, echocardiogram, and also the baseline measures again. We have to titrate very slowly because clozapine actually inhibits 1A2, CYP1A2, inhibits its own metabolism. So levels, even at low doses, peak up quickly and cause inflammation at the same time as suppressing white cell count. So there's a whole range of side effects, arrhythmias, severe sedation. When you get up to full dose of clozapine, if you stop it for more than a couple of days and restart it again, the tolerance goes and people can end up in ICU because they get severely sedated. So there's this period where inflammation blocks the metabolism, but that settles down after sort of weeks to months. But initially, we've got to start it very slowly. So it's 18 weeks of monitoring with a new prescription every 7 days. Generally, that's supposed to be done under, all prescribing's got to be done under supervision of psychiatrist. And once we get out to monthly monitoring, prescription can go out to GPs. But in rural areas and other areas, I think in some cases, there's no other option. And so we need to see everyone for the first 18 weeks in the community clinic. And we need to see the white cell count before we can prescribe. I guess in the 80s in Scandinavia, in Finland, there was a cluster of about 18 deaths, all linked to granulocytosis. So the mandatory monitoring is all around the granulocytosis, but it's actually the other problems that turned out to be sort of the most significant. We still see people with neutropenia, but all of the cardiac issues are significant. So you can vet clozapine on the ward, slowly titrate it up, and it's uneventful, but apart from sedation. But the patient's tachycardic on day 6. What could that be? What's the, given that we know that clozapine has cardiac effects, has effects on blood, other areas, what could that be? What's the differential there? No one's keen?
Myocarditis from online.
Yeah, that's very good. So 8% in Callan, we did a study the other year, 8% of people starting on clozapine get myocarditis or get raised troponin and tachycardia and echo signs of myocarditis. So we'll step through this a bit later, but the challenge is knowing, how to manage abnormal troponins, and this is where Chuck's comes in. But also, what else could be happening? Why do people get tachycardic? suppresses white cell counts. Yeah, so febrile neutropenia. So that's the key thing that we're monitoring for with the white cell counts, is looking for neutropenia. And so, but the other thing is that there is this non-specific tachycardia that happens with clozapine anyway. You know, and patients can become severely constipated. They can get bowel rupture. There's back in the day, there's actually a couple of cases of people that died on Glenside back many years ago when we weren't monitoring so closely. So there's a range of things that you need to consider, but probably, and pneumonia is quite common. So people get pneumonia infections on as part of the febrile neutropenia. So yeah,
Scott, there's a question from online. Is it caused by the uptake of dopamine?
No, these are, we're working on proteomic mouse models, and we're about to start a study in Callan looking at the evolution of the inflammatory response. It has some bizarre inflammatory responses. So it causes both myocarditis, but it knocks out white cells. And we don't know exactly why. And we don't even know if that's why it works, because there are inflammatory models of psychosis these days. So picking that apart is you know, if I can come back to you in 5 years and tell you that, I'll be very pleased. So we need to do, you know, full assessments, full workups. But if you have a look
Hang
at
on a
the,
sec, Scott, Chucks has got a question.
Yeah, Chucks, go ahead.
Contribution to that, I think the first thing to consider, like rightly said, will be the myocarditis. But as well, we have to remember that, like Scott said, other causes of sinus tachycardia. You know, the first thing, of course, get an ECG, confirm is sinus tachycardia. A rate of 1/3 is a little bit on the high side, and be sure there's no other arrhythmia going on. Once we confirm is sinus tachycardia, we must think of myocarditis first, but still remember other causes, and also inappropriate sinus tachycardia that can happen in that group as well.
So an ECG is a critical part of that process, as well as troponin and CRP. And we actually monitor weekly for the first 4 weeks troponin and CRP, and I don't think anywhere else in the world does that. That's given us a unique opportunity to actually see how this unfolds. And I think this is where we're working with sort of an international team publishing some of this now. And the case that we're talking about loosely tonight has just been submitted to a journal, and what the solution we've come up with troponin monitoring is part of that. And I put this slide up here just to show you the impact of granulocytosis, which is well monitored around the world. And we're working on data now suggests that after a year, probably the risk is the same between all antipsychotics. So it's the first year that's the most important. Having said that, you still find people getting it. But you look at the rates and the mortality rates with diabetic ketoacidosis, constipation and myocarditis. It's probably, we've got larger rates here than the rest of the world, probably because we titrate faster. And also we actually look for it because a lot of the commencements in other countries where the epidemiological data comes from, they titrate in the community, they titrate a lot slower. So, and that's, again, we're researching this for an important reason to see if we need to actually slow that titration down. The titration is probably dependent on ethnicity, varies with particularly people of Asian descent have less 1A2 enzyme, but also underlying inflammation. So if someone's obese, if someone has raised CRP at commencement, we probably shouldn't be starting them. That's the white cell count assessments that the traffic light system. So if someone's in amber, you have to monitor them twice a week until they go back into green. Tricks when people are in amber or keep going into amber is taking the blood later in the day. So because there's diurnal variation of neutrophils, if you take the blood later in the day, they're more likely to be back in the green. And we've done that recently with someone. And actually adding lithium increases white cell count. So you get a neutrophilia based on lithium. But if they're red, they've got to stop. They can't start again unless the monitoring system, which is sort of managed by the drug company, says, you know, we've got Jenny Kerno locally, who's the hematologist, that will provide that information. Chucks.
Yeah, that's an important observation I want to make to this. Is the fact that people from African descent tend to have a low white cell count. I guess it's something to keep in mind, because if you have like 3 or less than 3, it may still be normal for them. But I guess the population size is very small, but it's still something to consider.
Benign ethnic neutropenia, yeah. And in the States, actually, in other regions, they have slightly different monitoring to allow for that. And so we're actually getting a much larger African population in South Australia, in Adelaide. So that's probably something we should be thinking about a bit more. It's important. Thanks, Jacques. Here's the complex guideline that we have for monitoring, and this is for the first months. Is that basically we do baseline troponins, CRPs, we do echoes and ECGs to make sure everything's clear. Particularly over the first 28 days, if someone spikes a fever over 38, then you probably need to intervene and do a troponin and a CRP, particularly if there's tachycardia and other cardiac signs. Obviously, if troponin's elevated, that's a concern, and it might be a cardiac event, let alone myocarditis. But if both troponin and CRP are elevated, particularly if it's above twice normal level for troponin and there's high CRP, then that inflammation suggests that it might be a myocarditis. What we've found locally recently is there are different ranges across there's about 4 different machines that are used in Adelaide. And all those ranges vary. And we had this patient we're talking about, started on clozapine. He was negative when he left hospital, and we'll step through this, but then he became positive, low level positive, and we didn't know it worked. And this is where I called Chucks, and we started sort of stepping through and managing this. But if someone's got a fever, you need to actively, or if they've got, it doesn't matter if they've got raised white cell counts. That could be a problem. You always think, oh, they've got extra white cells, that's good. Well, not necessarily. If the CRP's up, it'll sort of inhibit the metabolism of clozapine. The clozapine levels could be high, so they might be drowsy. They might have myoclonic jerks, but also, potentially. If someone's got a fever, you need to consider myocarditis as well as a differential. So you do a whole range of tests and it comes back as normal and there's no potential source of infection. ECG is normal, but the tachycardia continues. So this is, he's just come out with a baseline kind of tachycardia. We can't do, we're not too sure. The EPSE is resolved. He's on clozapine. He hasn't got the strong D2 binding. It's a reasonable early response and titrated to 300, discharged to us, and we took over, but he was still tachycardic. And the question is, I don't want to see someone sitting at 120, 130 for the rest of their lives. That's got to end in cardiomyopathy at some point. And so I ran a whole heap of tests again, just to make sure that what they'd done on the ward was appropriate, because it's some weeks down the track now. But what else do you think we can do in this case?
Call Chucks.
Call Chucks, exactly. Anyone else? No? So because I'm comfortable doing this, is I added atenolol because I know that, as long as there's no risk factors for having an atenolol, I added that and I called Chucks and tried to get the rate control. And the tests were negative and the heart rate came down. So this is going okay, go to see Chucks. And then, so in terms of the treatment still not effective, you can add other things on a clozapine. So this is just a bit of a segue. Oops. Probably the most effective thing is aripiprazole. It counters some of the sedation. It's probably good for positive and maybe a little bit of the negative effects. Clozapine's better for positive symptoms and not as good for negative symptoms. The other thing you can do is add things like fluoxetine. Fluvoxamine puts levels up because it's 1A2. That's dangerous, and you need expert. But if you're in this range, then you need to start thinking about expert input, and there'll be a psychiatrist involved if there's clozapine anyway. And what I did was he was wanting more clozapine, so I kept increasing the dose and kept monitoring it. Once you get over a level of 3 to 50 micrograms per litre, that's considered an effective level, but some people don't respond up to sort of 900, 1,000. But the consensus maximum level is 1,000 micrograms per litre. And remember that the psychiatrist will always be making the dose adjustment, but if you're starting to see levels up that high, it's good to report them back to the psychiatrist to make sure that things that interact with the levels like stopping smoking, like infections, like other medications aren't being problematic. So heart rate remained at 100 and I'll just go through this in a bit more detail, and Chucks can comment. And so the problem there was, so what happened was I did a troponin test at another site, and it was with a different company who had a different threshold, and that troponin was low positive. And so then we didn't know what to do in terms of, so this patient with a higher level was actually getting symptoms of myocarditis or some sort of cardiotoxicity. And so we reduced the level very quickly. Chuck's suggested starting a Bravadine, and we sort of tried putting a bit of amisulpride in so I could take clozapine away. That actually made it worse. We tested him every day and then every 2 days as things were managed longer and stretched out. CRP remained in normal range. And as I dropped down, I was able to drop the clozapine back to 175, and he still had some symptoms, but they were manageable. We controlled his rate with the Bravadine, and over time, that cardiotoxicity dropped off to nothing. And now it's very stable. But because we maintained him on clozapine, he first started a part-time job, went to a full-time job, went to the same university adult entry course that I did to get into university, and passed that, and is now studying at university. And the only reason that we're able to do that is that we maintain the clozapine through this time, even though the troponins were positive. And so as part of that process, we worked out a level of 60 is probably tolerable, but you want to be working with a cardiologist, and you will be working with a psychiatrist for those tricky cases. So the challenge is trying to keep people on clozapine with all these side effects, being very aware of what side effects can happen, and intervening and sort of getting specialists in. Chucks, did you want to comment on that whole process? It was, thanks so much again for your input there.
Yeah, thank you very much, Scott. I must say it was a very rewarding experience and journey. And, the last time I saw this gentleman, he's done so well from psychiatric point of view. That's really encouraging. The thing with the myocarditis, which usually occurs within the first 2 months of starting the clozapine, is that unfortunately it runs a very wide range, a very wide course. It can be mild and it can be severe, requiring cardiogenic shock. But we are lucky in this guy that the only features we had was only the sinus tachycardia and the elevation in troponin, which was usually below 2 times the upper limit of normal. And in that case, it's actually encouraging to continue the clozapine, especially with normal echocardiogram. So when we did echocardiogram, they were all normal, and these days we're able to do not just the ejection fraction, but we're also able to do what we call the global longitudinal strain, and able to pick up early traces of cardiac impairment. So his ELS was normal, the cardiac chamber was normal, the ejection fraction was normal, and we continue to keep an eye on that. The other thing we did also was not to lose sight of his QTC. As Scott mentioned, all these drugs can prolong QTC and lead to ventricular arrhythmia, which would be a worse outcome. So we kept that in view, and it turned out very well. The ivabradine which we tried to use was because ivabradine itself will have no effect, one, on the blood pressure. It will have no effect on lethargy. I mean, no adverse effect on energy level, because it's only able to reduce the heart rate. But it's a very good medication to use in this condition, apart from the cost. So I think overall, it's a very good outcome, and the collaboration was excellent.
Thanks, Jackson. Yeah, I guess it just speaks, we've spoken a lot about communication and working together across specialties and with GPs, this is a sort of a great example of how complex cases can be managed and how important physical health can be because of medication side effects, and longevity and general health. And starting early, engaging people in their physical health, bringing in, we've got the benefit of lived experience people to bring in, but forming good partnerships with GPs is critical. As I said, part of my case reviews, the last question normally of the review is, have you contacted the GP? So it's critical and it's important. So I think, thanks very much, Chucks, for your input there. And I think that's probably time for me.
Scott, I've got a couple of questions from the online audience. So one question is, what time frame must a person be in hospital for their first titration? And in retitration, a person who missed more than 2 doses, what would be the expected admission time?
Yeah, the thing about clozapine is the longer you're on it, the more improvement you get. And this is a standard titration curve over a couple of weeks, but 200 is probably a bit underdone, unless maybe that you're of sort of Asian background, where you have a propensity for high levels and more side effects. What we tend to do these days is we don't have long to keep patients in hospital, and it's really about risk management. So if the patient's actually stable and healthy, they can start in the community. And you can ring up sort of the local mental health center will be involved, so the psychiatrist involved, but they can ring up and talk to the pharma companies who will actually supply a nurse for the first, because you need intensive observations for the first day, and then you can see them weekly. Do you want to talk more to that?
Yeah, we start people in the community. It's not that unusual. There are some areas that don't like to start people in the community, but other areas will. And as long as they've had a full workup beforehand and there is no cardiac risks, because if we start somebody in the community, we make sure that they have an echocardiogram beforehand. If there are any even hints of cardiac complications, they must be started in an inpatient unit. But otherwise, they're more than happy to start them in the community. Okay. And retitration, if a person misses a couple of days, then there's a full therapy interruption regime. Depending if a person misses less than 48 hours, then you can start they can just have their next dose and that's fine. More than 48 hours, then you need to start at 12.5 and retitrate up again, which is why we're always on to people about, don't miss more than 2 days, because you have to go right back to the start and start again. If a person misses more than 72 hours but less than 4 weeks, they go back to weekly monitoring for 6 weeks. And then if a person misses for 28 days, over 28 days, we have to restart completely the whole workup again, right from the word go, and they're back to 18 weeks of weekly monitoring.
The reality is, because of these strange inflammatory effects, is that people go back to, you're not at baseline risk because if you've tolerated it before, generally the second time around you can titrate a little bit faster. So there's 2 titration schedules, but there's no guarantee that you have to monitor and make sure that the adverse events that you're worried about the first time don't happen on the second time.
And this is why we're really worried about people who go into hospital, get admitted into hospital, and they might get admitted into hospital for a general reason, like break an arm or a leg or whatever, and they go on to an inpatient unit that's not a mental health specialist unit, and they don't get their clozapine because it's not a standard drug in every hospital ward. And then the doctors will go, oh, you've missed your clozapine. Here you go, here's 400 milligrams. And we've had incidents where people end up in ICU. So really important that we know when a person on clozapine goes into hospital, and we've got some alert processes.
And coming across them in your clinic, bringing up the local coordinator, that's kind of critical then, that communication. I guess, mental state concerns, any communication that it's in the patient's interest is in everyone's interest, I think. So, and both ways. I think we can definitely be better communicators back out into the community.
Might need to go to some of the resources. Jackie's got a hand up.
I've got one more question online, if we can just do this last question. Sorry, Jackie. Is clozapine a long-term solution considering the cardiac side effects?
She'll answer that.
So, yeah.
As I said in my speech, I've been on clozapine for 30 years and I haven't had any issues in regards to that.
So what we're talking about is a substantial proportion of patients that might have issues at commencement, everyone's at higher risk of long-term cardiovascular and metabolic and other issues than the general population, I think. But it has such profound effects when it works, and so it's worth the trial.
We have had a couple of situations in the past where people have developed cardiomyopathy, and in days gone by, we would take a person off clozapine. And there was a situation many years ago where a family came back to us and said, please put our loved one back on clozapine because the quality of life is much better than a quantity of life for that person. So now, since then, we haven't taken person off unless absolutely necessary. What we do is we work closely with cardiologists.
Yeah, so it's not a foregone conclusion. It's really about getting the best outcome for the patient in the end.
Any other questions? Over to you, Jackie. Looks like you've got your hand up as well to add something.
Yeah, it was just to say we're talking about clozapine coordinators and contacting people. I know as a GP, one of the things I always find hard is which bloody number do I ring and where do I find it? So I'm hoping that we've actually remembered to put that in the resources, Lisa. But a comment about how we go about that as GPs would be absolutely fantastic.
Yeah, if you just pop back the slide, Scott. So here are some resources that we've got. And the first one is actually the clozapine webpage. And so on our clozapine webpage, which is South Australian webpage, so it's available to everybody, you will actually find a list of numbers for clozapine coordinators on there. And we've got this handout sheet, haven't we, for people?
Yes. These slides and these resources will be handed out following tonight's session.
Did you want to go through the rest of them, Jackie?
Yeah, why not? If my computer doesn't die. The RNC College of Psychiatrists consensus statement has some lovely things in it, and some really, I think that's the one that's got the really nice tips about things around how to help people get more healthy meals. There's some really practical stuff. I like practical things. The therapeutic guidelines is just fabulous. I mean, Scott put all his life into that that table. He's done a good job. It was worth it, Scott. Thank you very much for what you've done with that. There's some great stuff in that too. And that physical health for people with mental illness is, we pulled out some of the things to put on the slides, but also some very useful things on that as well. There was something highly intelligent that I was going to say. It has gone. Never mind.
I'll just keep going on then, Jackie, while you're thinking about that. So the next is choice in medication. So you'll be able to get all this will come out to you and you'll be able to click on all of these links. That will take you to the SA Health Choice and Medications page with all the information, fact sheets for all mental health medications, which is fabulous. And then we've got our mental health GP shared care page, which is a one-stop shop for GPs to find everything mental health related. So that will take you to all of the mental health services. And there's a whole heap of good stuff on that page. Not that we're biased because we put it together, but we are. And then there's the metabolic health page for clinicians. Again, this is a web page for all things physical health for mental health consumers. There's two pages. One's the one for clinicians, and then there's one for consumers, and they get access to that. It's all on the internet. And then we've got the link to the Being Equally Well consensus statement on there, and we'll provide you with some of the other things around the Being Equally Well supplement that went into the medical journal last October as well. So there's a few things in there for you to read.
Lisa, one thing that we didn't include, but it's not just your head, I think, is the website for
that's
consumers.
The mental health, that's the metabolic health for clinicians. So when you click on that, you'll see it's called Metabolic Health. It's not just about your head.
That's
Many
right.
years ago, our consumer group came up with that saying, it's not just about your head. And so that's the tagline for everything physical health for mental health consumers.
And very nice. It's got lots of useful stuff on there, having looked through it. Yeah, absolutely. Oh, and I think the other thing I was going to say is don't forget I wish I knew whether Northern and Southern, I'm sure they do have mental health liaisons, but don't forget the mental health liaison nurses, because they're a good contact point for GPs if you're getting stuck. to help you navigate the community mental health teams. Would that be a fair cop?
It would be, but that's only for Central at this point in time. Sarlan and Narlan are working on it.
Well, all I can say is we're very lucky in Central because those two are absolutely fabulous.
Sorry, I just wanted to add something as well, because I think Scott picked a really good case for this clozapine patient. And it's a good example of how, you know, this patient wasn't really on any other medicines, and being a young male, there is like a higher risk of incidence for myocarditis as well. So even just because he's a young healthy patient doesn't mean that all these general health and wellbeing things can be overlooked, because it's very easy to think with the aging population and other people having all these comorbidities that those are the patients that we have to focus on in terms of, you know, other medicines that can cause QT prolongation and drug interactions and things like that. So I think it's a really good example to commend on. Yeah.
Thank you. And we've got to remember that clozapine is Gen X. Was started mostly in people in the 90s, and those people are, like myself, getting a bit older now. So we're starting young people on it. We need to manage them, but there's a whole other project that we're looking at maintaining clozapine and adjusting doses in the older people. And one thing I'll just add is that important to consider. This gentleman, we included cognitive therapy to manage voices. And including psychology input to help patients who are treatment resistant manage those symptoms is critical. And through that support and just sheer determination, he ignores the residual symptoms and gets to uni and does his thing. So that's another thing to think about, I think. Thank you.
Wonderful, thank you, Scott.
We've come on time, but does anyone have any final burning questions for our presenters or our panel members tonight, or those online in the room? Otherwise, I would like to thank you all for your attendance and participation in tonight's education session. We do ask that you please do take a moment to provide your